Welcome back to Discussions with Dr. G. Today's episode is Safe Medication Administration Across the Lifespan. I'm Dr. G, your sarcastic, possibly over-caffeinated guide to not poisoning people accidentally. Just kidding. Mostly. So today we're taking a look at why safe medication administration is, let's just say, more complicated than picking out the right flavor of ice cream for a picky toddler. There's a lot more at stake and, frankly, a lot less room for sprinkles. Let's start by talking about what really trips nurses up. Medication administration is never a one-size-fits-all deal. I get new students all the time who think, oh, it's just give the drug at the scheduled time, right? Yeah, no. It changes from an infant to a middle-aged marathon runner to, Mrs. Franklin with her 17 prescriptions and a purse full of hard candy. That's where your 10 rights of medication administration come in. Right client, right dose, right drug, right route, right time, right documentation, right assessment, right evaluation, right education, and yes, even the right to refuse. Try to say that 10 times fast at the Pyxis. And terminology? Seriously, y'all. If you're not clear what toxicity is, just picture that time when you ate sushi that had been sitting in the fridge a little too long. Bad things happen. Toxicity is when drug levels go beyond the therapeutic effect, so basically we overshoot the mark. And efficacy, that's not just a fancy way for does the medication even do what we think it's supposed to do? No. Point in all the 10 rights if the pill is a dud. Okay, so let's talk specifics, because honestly, nothing keeps you humble like doing weight-based dosing calculations at 2 a.m. If you work with kids, you know the struggle. It's all milligrams per kilogram, no shortcuts. And don't get me started on trying to coax a 5-year-old into taking anything that isn't grape flavored. Communication is everything, and sometimes that means you gotta bring your sticker game. It sounds silly, but a smiley face sticker can seriously save your sanity. Now let's jump to the opposite end of the timeline. Older adults. Polypharmacy is the name of the game. If your patient is taking 5 or more meds, that's officially polypharmacy. And it's way more common than people realize. The risk of drug-to-drug interactions skyrockets. And with things like the Beers criteria, nurses need to be extra vigilant about which meds increase confusion, sedation, and falls. Pair that with changing kidney and liver functions, not to mention sometimes cognitive decline, then you've got a recipe for a med error if you're not careful. I always tell my students, just because the script says give it, doesn't mean the patient can metabolize it the way a healthy 20-year-old would. Think about those renal and hepatic changes. Plus, you've got to monitor for things like orthostatic hypotension, aka people standing up and immediately regretting that life choice. And then memory issues mean that medication reminders and education are just as important as the prescription itself. Don't forget pregnancy and lactation. These bring even more fun to the table, to put it nicely. The old FDA letter system, gone. Now we use the PLLR. Much wordier, but honestly better, because medications aren't just black and white anymore. Every medication has some teratogenic risk, and your job is to know which ones are safest or at least less risky. That brings me to one memorable counseling session. New mom, heart condition, terrified that her essential meds would hurt her baby through breastfeeding. That conversation took a lot of reassurance and a quick check of LactMed, but ultimately, most heart medications have evidence on their safety. Or at least there's guidance. Just, absolutely don't wing it. Look it up. So let's dig into the real landmines. Medication interactions and reconciliation. You've got additive, where 2 meds pile on. Think drowsiness times 2. Synergistic, where they more than just sum up. like mixing alcohol and certain antidepressants, which is a terrible idea, by the way. It can totally lead to the person not waking up on this side of the dirt, if you know what I mean. And then you have antagonistic, which is basically where one medication cancels out the other. IV compatibility is a whole different circus. I mean, you can't just throw everything into one IV bag and hope for the best. Some meds will crystallize and clog the line, or worse, cause actual harm. Same goes for enteral tubes. If you've got, say, phenytoin and tube feedings, you got to pause the feed, give the drug, flush, wait. It's a whole dance. Otherwise, you'll end up with decreased absorption, and the next thing you know, seizure city. Now, the unsung hero, medication reconciliation. It's literally just making sure the patient's med list lines up at every handoff or transition of care. Sounds simple. It's not. You'd be shocked how many readmissions happen because someone missed a drug that was stopped or doubled up a heart med. That's about all the safe med mayhem we have time for this episode. Make sure you double check those meds, keep your stickers handy, and we'll catch you next time for more ways to not accidentally cause chaos with a pill cup. Stay safe out there.